We're here today with Dr. Castillo Salgado, and you have a fascinating career in history. Tell us a bit about what you did with the Pan American Health Organization, and I believe you worked with them for quite a few years.
Yes, I arrived to the Pan American Health Organization as a regional advisor for communicable diseases. In that time, I was in charge to provide support for the activities related to malaria control and prevention. And I worked extensively in the Amazon and in Brazil. We developed a new approach for characterizing the malaria transmission, and we call epidemiological stratification of malaria to recognize the local transmission and the factors that are affecting malaria. In those times, malaria was related to the mining, and particularly mining into the Amazon. But that was also for different other countries in the Americas. After that, I became in charge of what was called the Health Situation and Trend Assessment Program that deals with epidemiology and also in health information. In that regard, we did most of the strategic assessments for public health in the Americas and provide all the technical cooperation for the countries in all the countries of the Americas.
And you have degrees in law as well as an MD, PhD, and an MPH, is that correct?
Yes. I was very interested in law, and I decided to go to that career. And I worked as a lawyer for many years, and actually that's the way as I pay my medical studies. And for me, I started linking in the beginning with criminology, the linkages between law and medicine. But then I was extremely interested how community medicine could affect population health. And as such, I started coordinating different health centers in Mexico City, and I was very surprised to receive a lot of responsibilities in training the interns in community medicine at the National University of Mexico. I completed my medical studies, and then I decided to go to Hopkins, in which I finished my master in public health and then my doctor of public health. And after that, obviously, I started working with different agencies, the World Bank, the Inter-American Bank, with the governments, UNICEF, and finally with the World Health Organization.
It's quite an interesting career history. You come from Mexico City originally, is that correct?
I studied in Mexico City, but I was born in a town called Mazatlan in the state of Sinaloa.
Okay.
After that, my law studies were in Guadalajara, and my medical studies in Mexico City.
And currently you're at Johns Hopkins.
Yes. Currently, I am a full professor of epidemiology at the Department of Epidemiology, and also I am the director of the Global Public Health Observatory. This observatory is the center that Hopkins has for applied epidemiology, and providing the training of the new vision of public health and applied epidemiology, and also for providing support to many countries. And we had been in charge of doing the professional training for the national directors of epidemiology, assistant ministers, ministers of health, for the last 12 years.
And in your focus on epidemiology, you took note in your keynote speech tonight about developing a lot of metrics and standardizing metrics. Can you share with us a bit about that?
Yeah, as you know, it's very important for us to, in the relation of measuring health inequalities, we need to have good science. And in order to get good science, we need metrics, and metrics that are robust, that are validated, and provide the summary information that is needed for the public, for the civil society, but also for the governments. And as such, I have been developing new epidemiological metrics that will be applying in characterize the equity gaps in public health, particularly at the local level.
And you know, as you were speaking about epidemiology and metrics, to bring it back to the popular level, of course, the movie Contagion came to mind.
Right.
Have you seen the movie?
Sure.
And would you say it was a pretty accurate picture, or what?
Actually, yes. It was important to characterize the role of epidemiologists because most of the population, they don't understand what is the role of an epidemiology. And this type of epidemiology is what we call field epidemiologists. Field epidemiologists are in charge to get the proper information of the factors that are affecting specific outbreaks. And in that regard, they need to do a lot of searches and assessments of what is happening of the people that are sick and the ones that are not. But we also have the epidemiologists that are more analytical, the ones that provide this strategic that we call intelligence or epidemiological intelligence that go into the prediction of potential pandemics, for instance. We are very interested now in characterizing the early warning signals of potential outbreaks or pandemics at the global level.
And as you spoke about your time at PAHO, you spoke about developing standardized metrics, but also getting those measurements met and training senior hospitals and health ministers around Latin America. Can you talk a bit about that?
Well, actually, this is very rewarding because investment in professional training is something that is highly needed because we don't want to train in so many not useful knowledge. There is a lot of knowledge, but what we want is to incorporate applied knowledge that could be used for transformation. There is a lot of knowledge that is not used. One of the most gap is the knowledge gap. We have a lot of knowledge, but it's not applicable. And that's what we train these executives or these managers, these high-end politicians that wants to transform. And we have been so far very successful. We select 30 of the best managers of Latin America every year to be trained for 11 months. And this is supported by the World Health Organization and by the countries, and particularly Brazil, that Brazil is very committed with public health. And we have been actually training most of the senior managers in public health.
Earlier today, APHA, in the keynote address, we heard the head of the Centers for Disease Control also talk about metrics and measurement. In today's keynote, you also showed us some examples of measurement, geographically speaking, in Baltimore, and also binational measurements along the U.S.-Mexican border. Talk to us a bit about how metrics, big data, the capture of health statistics is beginning to progress.
Well, the first thing that we start noticing is that in some policies, health policies, try to provide one strategy for everyone. The only one that is working is vaccines. The rest you need to stratify the type of risks that are affecting the population. Let's put the example of perinatal mortality. Perinatal mortality in Washington, D.C. is highly affected by the low birth weight of babies. But low birth weight babies are because of teenager pregnancy and for smoking in pregnant women. Imagine that the strategies that will be needed in Washington, I will apply to Guatemala, in which those risk factors are not affecting low birth weight. There is malnutrition, anemia, many other things that are not the same. Then if we don't characterize the risk factors and the major determinants at the local level, the strategies that were very useful in other places, and we'd say, oh, well, let's apply that here, have not been working and have been wasting millions and millions, because the idea was that once that was working in one place, will work everywhere. And that's epidemiologically impossible, because the risk factors operate differently, even in a city, in one neighborhood versus other neighborhoods.
So would it be fair to say that right now, in terms of the field of epidemiology, it's really the discovery of the right faith-based metrics to begin to measure against?
Well, it's one part, yes, and there is a goal that measuring the main determinants are being relevant, but what we are now discovering more and more is that we had been measuring what we'll call very proximal risk factors. But we need to start looking at the distal risk factors. What are the difference? The distal factors are housing, our employment, our education, and those were mentioned by CDC and by the keynote speaker. And those, in the past, we were not having adequate methods to measure. Now we do have them. And in that sense, we need to teach the new public health professionals how to assess and recognize those factors that in the past were neglected.
Now, identifying the metrics is one thing. What about the software and the actual big data management? Where is that at?
Well, big data is important in the sense to recognize global trends, and since everyone use technology, and now the way as Google and many other main corporations understand the way as people communicate. And in that sense, we use social media to characterize the possibility of the messages that people ask regarding their own perception of diseases. And now the United States, CDC, and the World Organization start using those strategies and methods to have early signals. For instance, when we start seeing an increment in the sales of thermometers, means that this is where the population are perceiving that fever is now starting, and those are in the first days of a potential outbreak. Now we are documenting those in relevant parallel systems that we are now looking every single day. We are looking about the over-counter medications, and all the pharmacies are now reporting any increase in specific medications or equipment that the population are asking and buying. But also about the absenteeism of children in the schools. Then we call redundant systems that help us to recognize the early characterization of outbreaks.
20 years from now, what will applied epidemiology look like? What will the field look like, and the actual behaviors at CDC, WHO, what will emerge?
We think that we need to increase the quality of life of people. Epidemiology is characterizing the different profiles, and in that sense, we have a lot of new knowledge about epigenetics. We need to recognize that the way as people are living, we need to change that, because it's not only the regular aspects that we have been mentioning, like health services. Now we need to transform the way as we organize the communities. And in that sense, the lessons that the Latino community gives to the world is important, because it's a community that shares more than other groups, and it's the solidarity when people need help. And that's why explain what we call the Hispanic paradox. Hispanic paradox has been something that the science is exploring, why the Hispanic women that has their children, they don't have as much low birth weight as the middle class white. And it's because of this protection of the community when the woman is pregnant. Everyone helps. That's not what happened in many other groups. And that's what explains that children in the Hispanic population has much lower low birth weight, means that they have better low birth weight.
Very interesting. Any final thoughts to add?
Well, I think we need to move now into recognizing the new leaders of public health that, in my opinion, are the children. Children are the best ambassador of public health. When we start teaching them, they go to their houses and to their families, and they change the family. And we see even for adolescents that are drug addicts, they will not pay attention to their parents, the teachers, but they pay attention to the younger brothers and sisters. And for us, we are missing their role as ambassadors for health. We need to pay a lot of attention about children, because children are the future of quality of life.
Interesting insight to end on. Thank you very much.
You're very good.
Yes,
Excellent. Very good.